All right. Hey, everybody. Happy Monday. It is July 8th, not June, July 8th, 2024. And we are coming to you in Dolby Sound. We are live. Everybody is here on the panel today. Christine, Stephanie, Paul, Scott, Terry. We've got a great program for you today. Lots to talk about. I hope that y'all had a wonderful 4th of July week, a great 4th of July weekend, that nobody lost any fingers or toes lighting fireworks, and that everybody is doing well. So with that said, how is everybody today?
Good.
Great. Good.
All right, good. Lots of enthusiasm this morning. I love it. All right. So I want to jump right in and start with a last minute topic that Scott sent over to us about 8 minutes, 10 minutes before we went live. And it is something that was published in a Wall Street Journal article that talks about Medicare Advantage organizations sending out their own providers to do house calls. To do what, Scott?
To find diagnoses that the patients may have, which are risk-adjusted diagnoses that the payer may have, that the patient's primary provider may have either missed in their thorough exam of the patient, or may have not coded for whatever reason. So the insurance company, out of the kindness of their heart, wants to send their own PAs or NPs to the patient's home. Imagine how convenient that is, and the patient doesn't have to pay. In some cases, the patient's being offered a gift card. And the purpose of this visit is to give the patient a thorough exam and ensure that there are no conditions that were missed by the rendering provider. And those diagnoses, when they're identified, are added to the claim. And in one of life's great coincidences, the plan is then paid extra money, in some cases, $2,500 to $3,500 a year per diagnosis, because these are risk-adjusted diagnoses that are now being incorporated into the patient's record. Now, this Wall Street Journal article is subscriber only, I believe. I'm sure this news will start to find its way into other forums in the next few days. But one of the issues in the article is that a lot of these diagnoses turn out to be inaccurate. For example, the article talks about a very strong uptick in diagnosis of diabetic cataracts. Whereas when the reporters went back to the patient's primary providers, in a lot of instances, these were not diabetic cataracts; these were old age cataracts, and the NP or PA that was sent over by the plan didn't really do any work to make that distinction. But there's a couple of warning flags that I saw in this article. One of the warning flags was a patient was diagnosed with a condition during one of these visits that had to do with their leg arteries. And I'm kind of finding it in the article. The diagnosis itself is probably not overly important, but it was a diagnosis that had never been part of the patient's record, was identified by one of these plan doctors that went to the patient's house. And it turned out to be a diagnosis that everybody agrees the patient doesn't have anymore. But one of the things that the plan said in their defense was, well, this diagnosis ended up being assigned to the chart by the patient's actual provider in a subsequent visit. And one of the things I've talked about in this podcast before is when you're the rendering provider, you shouldn't be diagnosing things. You shouldn't be assigning diagnoses if you're not managing them. And you shouldn't be assigning diagnoses because you got like a gentle nudge from the insurance company. And that's a hard thing, right? Like, we're so hardwired in this that we follow insurance company guidance, right? How many times in this podcast do we say, well, this insurance company has a frequency limit of this, and that's the frequency for this company? Or how often do we say, this insurance covers this diagnosis, but this insurance may not? We're wired in the world of insurance writes the policies that drive our payments. So therefore, when the insurance company calls you and says, well, hey, we think this patient has type 2 diabetes with neuropathy, maybe you should put it on the claim, like, the first and easiest answer is yes. But as we saw in this article here, that ended up becoming a defense of the insurance company. The insurance company said, well, the doctor added it to the claim, and the doctor is now saying the patient doesn't have it, right? So this doctor has gotten himself or herself into a bit of a quandary, right? And so I think it's important to understand that these influences are out there. This article talks about an estimated $50 billion that the government has sent to these Medicare Advantage companies based on diagnoses arising from these plan provider complementary visits. Now, the insurance companies dispute those numbers. The insurance companies dispute a lot of the underlying work here. And I think it's important to point that out. But to me, the big takeaway when we talk about our individual physician practices, our medical systems, and our providers is the way in which this went from here comes the insurance company assigning a diagnosis from their provider of their own volition, a diagnosis that's not accurate, but somehow it got into the provider's infrastructure, right? And so imagine a scenario where this this nurse or this nurse practitioner goes to the patient's house and tells them you have this diagnosis, and then the patient calls their provider and the office says, well, why are you coming in? It's like, well, I have this condition, and that ends up becoming part of the chart, and nobody thinks that through. And it is a cautionary note in that way. Like I say, I hope this is a subscriber driven article. I hope that it gets more broad coverage because I think it's very important.
Well, I wanted to piggyback off that, Scott. So the Office of Inspector General on their work plan for the last few years now, since 2019, has been doing repeated audits on Medicare Advantage plans. They even came out with a toolkit last year because they saw so many errors. They saw patients that were scheduling appointments to come in to have a stroke or scheduling appointments to come in and have a heart attack. I know, Terry, but we can't make this stuff up. It's true. It's what the OIG found and they published. They said that diagnoses are not being supported. They are being reported erroneously. And then subsequently, last year, if you take a look at the Department of Justice press releases, the Department of Justice has been clawing back money from these Medicare Advantage plans. And I can't help but wonder that if they've got to pay back money to the federal government, how are they going to continue with their very generous bonus structure that they offer the Medicare Advantage plans or the providers there? Just food for thought, I guess.
Well, and to take it a step further, oh my gosh, this happens unfortunately more often than not, is that you have the parent, when patients get their explanation of benefits and they see something denied, they'll call their payer and they'll say, hey, usually, and they'll say, hey, why wasn't this paid for? Well, your provider billed it wrong. They should have put this diagnosis on there. I see that with screening where they said they should have had a diagnosis when a screening isn't a complaint or a definitive diagnosis, but they're saying do this. So then they call the provider's office and they yell at the staff and say, well, you billed it wrong and you should have done this. And I've seen actually the coding, billing, revenue cycle management staff say, okay, and they go in and put the diagnosis just to get it paid, and it's like, you have to be so careful. And Christine's right. The OIG is all over those, HCCs, because remember that costs money to Medicare. So it costs money to give them that extra money for those hierarchy codes. So and just not even talking about that, manipulating the claims for payment is not, it's not just a non-compliance issue. Now you're getting into legal issues and problems there, because now everything you're doing is for reimbursement and it's not what you did. And so this is becoming a problem too, where now they're trying to get the patient involved in this, and that it just really bothers me, because I think there's so much pressure on practices, like what Scott says, from not just a payer calling up, but now with going through the patient and saying you did it wrong, so you should do it this way. And I actually feel for the practices, because they're just trying to send out clean claims and then they're getting all this information. I know, Paul, you have a follow-up on this.
Well, let's consider the setting where we find ourselves right now. In the last week, CMS was forced to abandon the original grades that they handed out for Medicare Advantage plans, because the Medicare Advantage plans complained about, our ratings are going down, and then it's not fair to us that our reimbursement's going to be cut. They successfully sue, and then suddenly all their grades go up and they're getting extra dollars, but it's not enough. Now they have to go out to the patients' homes and assign diagnosis codes that are basically phantom diagnosis codes that aren't really there. And I wonder how this all intersects with the fact that there are no pre-existing conditions anymore. And now the way to make up that money that they have to pay out that they didn't have to in the past is just to adjust a few Medicare Advantage diagnoses, and suddenly they're getting dollar per dollar per patient that they don't deserve, that suddenly goes into a for-profit company's coffers. I find that very interesting as far as the timing.
Well, here's one of the things that I'd like for our listeners to consider. One, Medicare wants to be out of the insurance business by 2030. That's why greater than 50% of all Medicare beneficiaries at this point are enrolled in a Medicare Advantage plan, because Medicare doesn't want to deal with it anymore. Number two, remember, the addition of these HCCs means that the complexity of the patient has gone up. And as a result of a higher complexity, that means, in theory, the MAs are using more resources. It's a higher complexity of them to be able to manage the outcomes for these patients. The bottom line comes down to this. And I agree with Scott or whoever said this a little while ago. If these diagnoses don't exist and they are being added on, as somebody referred to them as a phantom diagnosis, that constitutes a fraud. Now, we have seen some of these MA plans be dinged for over exaggeration or exaggeration of how severe patient conditions are, right? Just do a quick search on, MA plans fined by HHS-OIG or DOJ. You'll find quite a few of them. But at the end of the day, I think it comes down to one last piece. Insurance companies telling patients that the provider was in the wrong. Because how many times do we, or do you as individuals working for a hospital, health system, or provider group, pick up the phone and ask for an explanation for why something was denied for a medically necessary reason when you followed the medical coverage guideline, when you followed the local coverage determination or the national coverage guideline? And the first thing they say to you is, we can't give you any coding advice. But yet a beneficiary calls and says, why was my claim denied? And the first thing they say is, well, they used the wrong diagnosis code. Had they used this diagnosis code, and listen, if it happens once or twice, you think, okay, this person may be full of malarkey because nobody had an insurance. But when you have patient after patient after patient calling and saying, my insurance company said they would have paid the claim had you used the right diagnosis code, well, we know that's not BS. And we know there's a systemic problem. And I think a lot of folks who are watching us on a platform outside of YouTube don't get to see some of the comments that we see coming in from other platforms where people were watching us live. And one of our listeners actually said, why does everyone assume that insurance company reviewers and staff are smarter than we are? Well, we on this panel don't believe they are.
I spent 6.5 years on the insurance carrier side. I can tell you that is clearly not the case, particularly when you get into the customer service department.
So, Stephanie, I know you had a couple of things that you want to talk about from a coding and auditing standpoint that you're seeing with these MA plans.
Yeah. So one of the things that's actually been frustrating to me is getting feedback from people. And let me just say this. It's not that I don't welcome, different viewpoints, but there have been times where I have been in settings where I'm teaching risk adjustment, for example, and someone's pushing back on me and saying, oh, risk adjustment and diagnosis is completely different than what you do when you put those diagnoses on the claim form for an E&M service or any fee-for-service item. And the reality is that they're not. The information may be used for different purposes at the end, but the process to get there still has to be the same. So when we're looking at accuracy, and we have not only the payers who are out there trying to push these things to get more diagnoses, it's even worse when we then have people on our side of the industry who are working on the provider side who are also trying to push and skirt that line. So we have to be aware, yes, there is a lot that goes into risk adjustment, but when we look at AMA's perspective, for example, with the E&M guidelines and their definition of the problem addressed, it's the same exact mindset when we're looking at this for risk adjustment. And the reason for that is if the provider doesn't address it that day, we don't get to account for it. It doesn't matter at that point. So we need to look for those similar threads, really, when we're looking through the documentation to help the providers to understand as well, because a lot of them that I work with, for whatever reason, view these things as completely separate and unique from each other. And it's like, at the end of the day, you need to do this for your fee for service, for your E&M leveling, and that also trickles over into your risk adjustment.
Scott, what are you thinking about?
A couple things just to tie this together. The part of this story that I read this morning that kind of aggravated me a little bit as well. You think about the damage that this does to patient-provider relationships in some respects, right? When, so we to the comment earlier about what we may know on the panel, like, we know things, right? Like, we know at least some things. I mean, people in my house may argue I don't know anything, but we know some things, and patients don't know very many things when it comes to like what goes on behind the curtain of our industry. They know they go to the doctor, right? So imagine if you have a doctor and you've been seeing this doctor for a number of years and you feel like you're receiving good quality medical care. And now this nurse practitioner or PA shows up from the insurance company and says, oh, well, I don't know how your doctor missed this, but you have, this condition and this condition and this condition. What are you going to think, right? Like, you're not going to think necessarily, well, I think this is just a way for the insurance company to get paid this, or this is a way for this. One of the things you're probably going to think is maybe my doctor sucks, right? And that's not a great lane to go down, especially as we talk about, the number of times that these things are inaccurate. And so I think, look, part of the culpability, or part of the reason these kinds of things happen is that we do have to acknowledge that the diagnosis coding within our side, within the physician practice side, is often imprecise. It often has, contradicting information within the notes. We have not always on our side done as good of a job as we could have capturing the things that we're discussing and capturing the things that we're managing. So when you step into this very binary world, like, is it on the claim or is it not on the claim? Like, I had a 10-minute conversation with the patient about the danger they were in due to their obesity and their BMI and the impact on the diabetes. But I didn't code that, right? I didn't center it in the note. And so the thing that we have to do is we have to make sure that our diagnosis coding is reflective of the things that we're managing, and that it's precise and that we understand what these rules are. Because there's two things that will arise from that. First of all, we'll almost certainly get a better or more complete picture of your patients at the diagnosis code level, and you'll be better prepared for these kind of antics from the payer or these kinds of behaviors, right? Because my fear is, like I said before, you just walk into that trap where the payers interfered with your patient relationship and the patients come in and said, well, I think I have this and this, and you just say, well, okay, let's put it on a claim, right? And you've sort of backed in, it's like when your buddies all tell you to jump in the car and we're going for a ride, and the next thing you know, you're robbing a 7-Eleven, right? You're like, well, I just thought we were driving to the beach to drink. It's kind of, you just need to be sure that you understand like what you're getting into.
What kind of friends do you have, Scott?
Yeah, that was
not
going to
good
be
one,
my
not
question.
good, not good ones apparently.
I have a piggyback off of this one
Go
more
ahead,
time.
Christine.
So let's just make it very simple. When we're talking about reporting these conditions, I think that maybe, I don't know who influenced it. I don't know where it came first, but just pointing out that a patient has a big nose doesn't mean that we need to pay the doctor to say the patient's got a big nose. Now, I'm not saying you do. I just said the patient. Listen, I'm just saying. But think about that. We've got the AMA who is giving us an explanation of what a problem is. It's something that's addressed. You've got the ICD-10 guidelines that also say the problem was addressed. And all of those things factor into the claim for a service that was rendered. So addressed means that you did something besides point out the fact that the person had a big nose. What are you going to do about it? Why is that a problem? What can we, does it mean I can't breathe properly? Like, what is it? So I think we got to get back to the reality of, regardless of who told you to put those on the claim, we've got clear definition from AMA, clear definition from ICD-10 that tells us we only report the conditions that we're absolutely addressing today. You have a big nose, you cannot breathe, you need a medication or a surgery. Other than that, please don't tell me I have a big nose. It's rude, and I don't want to pay you for it. Sorry.
So
Paul,
this may be slightly odd and weird and tangential, but isn't this a great argument, finally, after 3.5 years, for updating your examination templates in your electronic medical record system? Because when you're talking about somebody from the outside coming in and saying they have this condition and that condition and this condition, how believable is it when somebody comes in and looks at your electronic medical record system and there's a lot of no's in your exam template and nothing is being picked up, and we don't have to count it anymore. We just say it's a medically appropriate exam, but what in that examination template is correct? And as far as the big nose thing, I teach the patient to do a Jimmy Durante impersonation and send them on their way.
After what Christine said, when you said a lot of no's in the exam, it took me a second to realize you meant the whole exam and not the ENT portion of the exam.
Not a lot of no's in the end.
A lot of no's.
All right.
With this, and this could lead into our next topic, Sean, is
Yeah.
I rarely do on-sites anymore. I'm about 90% virtual as far as auditing, education, everything. But I do have those particular doctors says, please come, just look at my workflows, see what's happening. I'm like, okay. So, going in, just trying to assess the revenue cycle management department. And I remember walking into this one, and it was recent. It was in the last 8 weeks. And it's funny because it was beautifully done. But then when you look closer, you're like, oh no. So they had in their billing office, which was pretty big with about 12 billers and coders, they had cheat sheets all across the wall, and they had payer names on them. And so I was just looking at them, and they had diagnoses and different. I wish I brought Paul with me because he would have had a field day. This would have been super fun. And so, and Scott would have just been like, I need to go down the street and go to Jersey Mike's or something. But anyway, it was just, it was just really kind of amusing because, and not in a good way, because I said, so what's this? And they're just like, oh, so when a patient comes in, and they're coming in for an echo or a stress test or anything, we know what diagnoses will get paid for each provider. And I said, well, don't you go by what's on the report? Simple question, I thought. And they said, well, yeah, but those aren't always covered, whatever the indication is or whatever the result is. So we just make sure we know what the payer is and then pick a diagnosis from there. And I'm never at a loss for words. You guys know me, never at a loss for words. And I really, at that point, and Sean, I'm going to let you chime in on this one and take the defensive side of, I do a lot of payer audits, and I was just like, oh my gosh. But here's the kicker on this one before I send it over, is that some of the cheat sheets, and we don't use that word, who are you trying to cheat, actually was on the letterhead of the payer. So it wasn't self-created within the practice. Some of them were, and they just said these are for Medicare, but there was 3 that were from large payers who I will not say who they are. And they said that, no, we pulled these off their website. And on the actual sheet, Kathleen, one of our listeners, it actually said who the payer was and called it a cheat sheet. And I just went, boy, if Sean was here, and that's all I think, what would Sean do? If he was here on behalf of we need to have bracelets made that up, what would Sean do? Basically, if you were there, on behalf of trying to defend a physician, or even on the other side, I don't know if you do payer work, trying to say, no, the payer's right here. I am on both sides of the aisle. You just couldn't defend the physician at this point, in my opinion. But then you'd also have an argument saying, but the payer made me do it. I just think this is
Yeah.
weird. I mean, the payer probably would say something like, well, we're just giving that as a guideline of what we do cover, not that they should use these codes, but that's not how they took it in the practice. I mean, Paul, have you ever seen that?
Well, I don't worry about what you do or I do or Sean does as compliance professionals. What happens when the guys invests with the letters FBI on the back of their shirt or jackets come in, and you've got something right in your cubicle that says cheat sheet in large print?
Exactly. Who are you trying to cheat?
So
you have to be
are you out of your mind?
Yeah. So
as wallpaper.
Unfortunately, there's not many scenarios after 30 years that I've not been tested in a courtroom to have to either explain from a defensive standpoint or target from a prosecution standpoint, right? What I would say from a defensibility standpoint, I can't defend the term cheat sheet, but what I can say is it's a term that is widely used in the industry. Does it have a negative connotation? Probably, because kind of means we're cheating somebody, but it also could mean that, hey, it's a shortcut for us not to have to go searching for these things. And this is kind of how it all flows from an informational standpoint. I think Paul used a great term, and I use this in my arguments all the time. They're guidelines. The things that are released from insurance companies are, unless they have been promulgated, unless they have gone through a formal rulemaking process, are not law. They're not statutes or acts or regulations. They are guidelines, and guidelines are best practices. Now, with that said, does it make it right? The answer is absolutely not. Now, from my perspective, because I do use reference materials to make my life easier, and I do have them broken down by payer. The payers do provide in their MCGs and in the LCDs, LCAs, they do provide us with diagnoses that support medical necessity. Now, those diagnoses that support medical necessity is not a cue for you to just pick one willy-nilly from the list and add it to a claim because you know it's going to get paid. If your patient, so let me stop right there. Providers, PAs, NPs, MDs, DOs, they are notorious for just giving us generic diagnoses, right? Unless you have somebody who's really gone to a coding class or who's really OCD about making sure they dot the I's, cross the T's, things of that nature. Most of them give us a diagnosis of diabetes, and they leave it up to their coder or biller to figure out how to take it to the highest level of specificity. But to the best of my knowledge, none of us, with the exception of Terry, have a piece of parchment that indicates we have clinical competencies, right? So how can a provider expect a non-clinical person to read clinical documentation and extract from that a diagnosis at the highest level of specificity that would be recognized as a payable diagnosis? This is where providers get themselves, I was going to say something really bad, but this is a PG rated show. This is where providers get themselves into a lot of trouble.
Well, Sean, the only thing the general guidelines on ICD-10 allow coders to do when it comes to, I don't want to say adding information, but extrapolating information that is clinical is laterality. It even says if that's in the note, you can put right or left. They're like, if that's in there, go right ahead. But like you said, you can't upcode based on what you think it could be. The clinical has to come from the physician. And if you don't know, you have to query.
That's right.
But now, I see that all the time, Terry. I see coders that look at lab values and that will give someone a diagnosis based on what somebody said those lab values were, not taking into consideration that that lab could have been elevated due to a medication, another stressor. The provider's not even treating that condition, yet the coder feels it upon themselves to cross that line and make that interpretation.
Well,
Right.
and
Well,
I always try to explain this very carefully. And I know it upsets some coders. Listen, I cut my teeth in this industry as a coder, okay? In 1995, I got my first job, and in 96 I got my first coding certification, my CPC. Okay? So when I say this, just take it with a grain of salt. Coders are not clinicians unless you have that piece of parchment paper after your name that indicates you possess clinical competency to be able to do that. I don't care that in studying for your CPC, you had to take a section on anatomy and physiology. It doesn't make you a physiologist. It doesn't make you an anatomy specialist. It means that you possess some fundamental basic skills to understand what is a rotator cuff, what is the cerebral cortex, and what is the coccyx. Okay. So at the end of the day, from a prosecution standpoint, because I have worked on the prosecution side, if I were to be given a 302, which is the form that is completed by the FBI agents or the OIG special investigative agents, right? If I were to review that and attach to that are pictures of wallpaper and it says cheat sheet for Blue Cross Blue Shield or cheat sheet for Medicare, the first thing that I would say is, well, it means that they've figured out how to cheat the payers to get claims paid, right? So there's two ways that you can argue these things. But the bottom line is there's nothing wrong with having reference sheets, but don't cross the line and think that having a payable diagnosis is an open invitation for you to simply select one of those because your provider did a crappy job of giving you a high specificity level diagnosis. And now you take it upon yourself to use Terry or Christine's word. You took it upon yourself to add a payable diagnosis. Stupid.
well,
And
also,
you
Sean,
are complicit. You are
also
now culpable for the potential filing of a false claim.
false claim.
And remember, any person who files a false claim, who knowingly or willfully or with deliberate ignorance or with reckless disregard files a claim that is not true, it's on you, my friend.
Yeah, Steffi and I were texting before over the weekend with Christine too. It's a girls' club. Sorry, you guys weren't invited, but we Stephanie started it, and then I chimed in, and Christine was awesome with her emojis and gifts. But it was really funny because, for example, I had a doctor who wants to bill preventative and office visits together. And fine, if you've read the CPT guidelines, if during a preventative you find an abnormality that required you to address, another problem or something that you have to do, not just basically refill meds, it's something that you encounter it during that, then that's fine. And the documentation that I was auditing actually said, it quoted because somebody was scribing for the physician, and it basically said, we're going to go ahead and elevate your blood pressure today so that I can get the additional visit paid. Set it right in the note. And the patient agrees. And so we're going to put down slight elevation so we can also get an office visit. And I had to read it again. This was again a payer audit. And I was just like, what? And they sent this to the payer, asked for records, and they send this to the payer going, we're fine. And Stephanie, what was yours? You had one that was very similarly silly.
Yeah, so it was in dermatology, and the physician basically noted, or a PA or whoever, noted that they spoke to the patient about two different diagnoses and how the one would be covered by the insurance and how the other one would not be, and asked the patient and put it in the note and said, I asked the patient which diagnosis they would prefer me to use.
Which one they'd prefer. So, it's like trying to bill level 5 and the last thing you put in your E&M service is PRN a year. So patient return is needed. You're telling the patient, oh, come back whenever you feel like it, but this was a high-risk visit.
And I want to be clear to
Oh
all
my
of our
gosh.
listeners. Yeah, I want to be clear to all of our listeners. Some of this stuff that you hear us talking about, this is not made up stuff.
No,
This is
we wish.
stuff that is legitimately documented in medical records.
We're not on comedy tour.
Yeah,
No,
this is the kind of stuff that attorneys will send to us. Stephanie, Christine, Scott, Paul, Christine, they review this information. Our team from Doctors Management will provide me sound bites and bullets that I review in making a determination as to whether or not we're going to take a case. And when I see crap like that, I'm like, do yourself a favor, call the prosecutor and simply find a way to settle this thing, because you don't want to take this to court, because that's just plain stupid. And let me tell you something. Patients have become very in tune with their benefits from insurance. I can't tell you how many times I just did a physician shadow not too long ago, and a patient literally talked to the doctor and said, listen, I know because I was reading about this policy and I went online and did some research, and they actually handed the provider who I was shadowing some pages of information that they pulled off of the interwebs. And they said, look, these are the things that you need to say in the medical record about me and the things that you need to avoid saying about me in the medical record. And this will make sure that my claim gets paid. And I literally sat there, and Scott knows for a fact that I just did this physician shadow.
Oh my
I
God.
literally sat in the corner of the room, silent. And
Was your jaw on the floor?
no, I'm very emotionless. I don't react. I literally am a fly on the wall. And when we walked out, the provider looked at me and said, this is what I deal with on a daily basis, multiple times a day. What am I supposed to do when they tell me this is what they want me to put in the medical record and this is how I need to code things, and don't put this in there? I said, simple answer is, you're the physician. You say, thank you, I appreciate you sharing this information with me, but I am the clinician. I will make the determination as to what goes into your medical record and what doesn't. And I can assure you, I only provide complete, accurate medical records to ensure that what goes to an insurance company on a CMS 1500 form is able to be identified in my documentation, because I ain't going to jail for anybody for a $20 visit. Now, you don't have to say all that stuff to your patients, but I mean, they'll get the gist. Simply say, I'm the physician. I will determine what goes into your medical record and what doesn't. Please don't ask me to do things that are not correct. Leave it at that. All right. Go ahead, Scott.
Yeah, I don't want to get sidetracked too much, but
Yeah.
when you said that, I couldn't help but note it's important. That guidance is important, and it's important that providers understand that they're able to give that guidance within the organization. Because when I have those conversations, with clinicians, because I see the same thing you see, the patient comes in and they know what their benefits are and they know what they want. And a lot of times it's something that's seemingly more innocuous, right? Like the patient goes in and they have a URI and they want an antibiotic, and the providers understands, well, it's not going to do anything, right? But then the provider's concern is the patient's going to get one of these surveys in the email and just strafe the provider over it and talk about how bad the provider was, and that's going to get held up as this thing. So I think organizationally there needs to be that synchronization, because what Sean said is very important. But a lot of providers will come back to me and say, you know what, like, I'm stuck in the middle here because I'm going to get some sort of review from the patient, because in some ways the patients will treat this like it's not Chipotle, right? Like the patients come in like they're ordering off a menu and they kind of know what they want and why. And so I think we have to make sure that when we give that guidance to providers, that we're also supporting them when there is some sort of patient commentary about that. Because Sean's right, we shouldn't be doing things that we're not going to get paid for. We shouldn't be doing things that are inappropriate. But I also understand, at least in my work, the provider's perspective on the other side of that coin as well.
Sean, can I mention something? It's going to
Please.
be a little controversial, and I know we don't vet what we're going
You,
to say.
Terry?
So,
Never.
well, I just want you to know, I know we're live, so I'm going to be very sensitive to the topic. But this
Hold on, I gotta get Terry's mute button ready. Hold on.
you do. This has just come up, and I just want to caution people out there, because we don't ever talk about it. But I'm seeing that there's been a couple of practices. I just finally saw it hit the OIG desk on gender transition surgeries where they don't have authorization, they don't have coverage for it. And there's been physicians who've actually come to me and said, what do I do? Because I'm being told by the patient I could be sued if I don't do it, and they want me to charge it as a hernia repair, or they want me to charge it as an appendectomy. They want me to charge it as something, and they don't want to be labeled with gender dysphoria, which is actually a mental condition.
Yep.
And, I'm just using that as an example because it's in the news right now, and it's really starting to come to out fruition, regardless of your position either way on it. My point is that you have to be. Well, I don't even want to say you have to be careful. You can't do that. You
Well,
cannot.
hold tight for a second
Yeah.
on this, because I know where you're going, and
Yeah.
let me just kind of preface where this is going with
Okay.
this information. Okay. These are critically important topics. Okay. They're not only social issues, these are legal issues. And these are issues that are left to state legislatures. To Terry's point, where she's going, irrespective of what the service is that the patient's wanting to have done, we never bill something that we didn't do because we don't want to fully disclose what it is that is being asked of us. If you find yourself in a situation where you are dealing with this type of a sensitive, highly flammable topic, the best thing to do is to seek legal guidance, contact your practice attorney, contact, an external attorney that works with your group who understands this type of legislation and what's going on and how to handle it. Listen, we live in a litigious society. We operate in a highly vulnerable industry where people threaten litigation all the time, and some people carry it out. If you are being asked to do something that it makes the hair on the back of your neck stand up, that's a bad thing, and that means you need to quash that issue right then and there. This is not a political show. We don't take political sides, irrespective of what each and every single one of us believes personally in our personal life. That's not what we're sharing on this show at this time or at any time. This is a serious medical issue that is going on, and it requires legal guidance. But for Terry's scenario and what she's talking about, this is something that if you have been asked to provide a service, but to bill it as something different to avoid it being flagged by the payer, the answer is absolutely not. And if you have a provider that does that and takes on that role and responsibility for whatever their political cause may be or whatever their medical belief might be, that's on them. And I tell people all the time, data is king when it comes to the insurance companies. And if this is something that they decide to randomly pull because there's no other evidence that the patient had, we didn't do a HIDA scan, but yet we billed a gallbladder removal. We didn't do a CT of the abdomen, but yet we did an appendectomy. We're going to have major problems. So just keep that in mind. There's always people smarter than me out there. So, all right, Terry, I didn't mean to step on what you were saying, but go ahead. Or Scott or Christine, whoever.
Yeah, no, you made my point. I was just saying that's just one of the things that has come up lately. The general statement of obviously not billing what you shouldn't do. I know it happens in derm because that's so cosmetic. Sometimes they try to find a diagnosis that matches to get it through. But when I started seeing this on that very sensitive topic, sensitive, discussion, surgery, I just want to be careful and make sure that everyone out there who's even involved in anything like that realizes that, especially after the conversation about the patients are telling you what to do, don't fall into that trap. It's more legal than you think.
And especially in derm, if you're trying to get Botox and you want that covered because they don't pay for Botox a lot of times for
they do in dentistry. Go to your dentist,
right? Because they don't pay for it. Listen, the insurance company, if they call you and they come to do an investigation, and as they're asking questions, your face doesn't move because it's so tight, they're going to know that you did not have that other procedure. They will know that
I was better than Sean just now. Sean just went, Scott, help us out here. Get it. All
right, come on. Go ahead, Scott.
Look, fraud is fraud, regardless of how controversial the surgery or the work is, or regardless of where we are societally. Fraud is fraud. And if you're doing certain types of services and they're, a regular part of your practice or a semi-regular part of your practice, you ought to have a foundation in place of the things and steps that you take to make sure that you're performing that service in a compliant fashion. I mean, we could take what Terry talked about and apply it to something that is maybe controversial in a different way, like something like the use of Ozempic or some of these things where, it's very easy to say, well, the patient has some sort of condition that would enable it to be covered, but they don't, and the flip side, we talked a few minutes ago about patients being very sophisticated about their benefits these days and patients being able to come in and say, well, I understand that I get covered for this in this way. That works on the flip side too. Patients see things online, patients talk to their friends, and patients are basically sometimes told, well, if you want this to be covered, you have to go in and say this. You have to build a narrative that's different from maybe what you're experiencing. And look, I think as I tell my clients as a non-clinical reader of notes, like I can be fooled. Because the provider can put something in documentation. If the provider wants to, create a fraudulent service line or service model, I, as a frontline remote documentation reader, can potentially be fooled. And that's why we shadow providers, we do these deep dives on time, and we do all this other work. And so if a patient's coming in and they're telling you a set of conditions, you have your due diligence to do to determine how accurate or inaccurate you feel that it is. But, at the end of the day, if you believe that you're potentially being, tricked or conned, you don't have to do that work. You should do a certain amount of due diligence or bring in a chaperone or a witness or something like that. I did this as a slightly different example, but I did this shadowing project years ago in urgent care, and this lady came in and I was in the office with the provider, and this lady, like, pain everywhere, right? She's just like, I got it here and I got it here, and the doctor asked her to walk across the room, and she walked like, she had just been like hit by a car while she was like walking the appointment. She's like, I barely move, right? And so the clinician, to his credit, was like, well, let's do a workup. Let's get some imaging. I may have to send you to the ED. This seems very serious. And the patient's like, I really don't want to come to the hospital. Just wanted to come here. I'm sure, some Vicodin or some Percocet or something will get my hash settled right away. So the doctor wouldn't write it for her, but he's like, look, I got to go make a call to the hospital. I'm going to start to get a chart note together. So he and I go to the triage area while he starts to prepare this stuff for her. And she comes barreling out of the room, and she left that exam room like somebody set a fire in there. Like, she just ran out of the office, right? And I just looked at the doctor and I was like, it's a miracle. And so the point of all that is patients come in with different agendas and sophistication levels. And while Terry brought up what in our current time is maybe a controversial topic, fraud shouldn't be controversial, right? Like,
That's right.
and so if somebody's going to tell you, you got to call this a hernia, it's like, no, like, let's bring that up in court, or let's do whatever we need to do, or like I say, get a chaperone or a witness in there. And to me, I think that's really important. Like, anytime you're trying to manipulate something to make it payable, whatever that something is, you're opening up a real risk for yourself.
I just wanted to jump in real quick.
Yeah, go ahead.
Just to touch what Sean, you and Terry both were saying. I think that a lot of providers don't realize that these patients don't live in a bubble, that they do see other providers. They get prescriptions. They have, counselors. They have other people that are involved in their care throughout their time period. And while one provider doesn't absolutely see all those other things that are happening, the payer does. So I had a brief time on the payer side, and I can tell you that part of it was seeing the prescriptions that came in, the imaging that was ordered, the labs and the lab values that came in from the labs. All of those things are seen by the payer side. So when you are trying to pull a fast one, sometimes either the dots point in a different direction or the dots don't point at all as to why this would be, this procedure would happen, or this, you would prescribe this when there was nothing that led to it. There's always a bigger story behind the encounter itself. The provider's only privileged to what that patient told them at the moment, like Scott was saying. So I think we do need to remind people that there are other things happening in the background that could kind of shed a brighter light to the situation and get you in trouble.
Yep. And to Scott's point of the patient, receiving nothing short of a miracle and running out of the office, it reminds me of all the times I get ready to board a Delta flight and there's 27 people in a wheelchair, but when we land, there's only 2 wheelchairs waiting for them at the gate to come off. It's something about that recycled air inside the tube that miraculously cures everybody's
you get to
sclerosis.
35,000 feet, that circulation starts moving a little differently, it gets going.
It's not a Biscoff cookie, it's the Eucharist.
That's right. All right.
I say that about my dad. He's got mobility walking to a slot machine is far different from his mobility walking from a slot machine.
All right. Last topic of the day, because we got about 9 minutes in which to accomplish this, and I think this is a great topic. Terry, I want to throw it to you, and then we'll go around the horn on this one. Waiving copays for physicians or their family members.
Yeah. So this has been a topic over, gosh, I'm in my 40th year of healthcare. So it's been going on forever. And back in the day, long time ago, and to quote Scott, back in the Little House on the Prairie days, maybe people did that when it was, trading chickens and, basically you're bartering for your services. But we're in the time of compliance and Medicare regulation and, bad optics and contracting. And first of all, when you are waiving any kind of out of pocket for a patient, first of all, are there certain rules under Safe Haven that it's allowed when the patient has a financial hardship? Yes. But the biggest thing that you have to take away is that payers are entitled to the same discount you're giving the patient, not just the patient. So you have to know that too. But just to keep on the topic of, no charging physicians, that's really not an appropriate thing to do. And you can find it in many of the commercial plans. But here's the thing you have to keep in mind. First of all, let's say you'll say an ER physician comes to your practice and they want to have a colon screening and there's something found and your doctor says, well, no charge. That's a buddy of mine from the ER. But this doctor refers patients to you. Uh-oh. Now you're paying for referrals, and that is absolutely an illegal situation that you're dealing with. Also, can't a doctor afford it? Where's your financial hardship situation? AMA won't protect you. They're very specific that this is not part of the Hippocratic Oath. It's not part of anything we do anymore. But it's also unfair to offer free services that have value to somebody that's not Medicare or somebody that your lowest service in the office financial wise has to be your Medicare patient. So this is where it gets into such a gobbledygook of regulatory issues and contract issues and just really inappropriate practices. Don't do it. It just can absolutely be a problem. And I'll send it around the table because it's more than just, citing the Federal Register or citing the contract thing. It's just bad practice.
Last week I saw another interesting thing in a note. I don't know what it was about last week, but there was a particular patient that was receiving an injection and an E&M service was being billed that day. And the provider had noted that the injection was done pro bono in the note. And then they upcoded their E&M service and it still was going to the insurance. Yeah. So, again, we got to be careful of what's in the notes and what the providers are thinking. But this is one thing that I find when I work with clients, that there is not a general understanding throughout the practice as to whether or not there is a policy and how this is supposed to be done. A lot of times it'll be one of those things, kind of what you're saying, Terry, where the physician wants it. It's their friend, it's their golf buddy, whoever. They want them to have a discount. And I actually had a situation earlier this year where there were discounts happening and they said, well, we do that because Dr. So-and-so from this other practice refers people here. And when they do, they get a discount because he referred them.
See all the face plants here? We're hurting our heads here with face plants.
I know.
That's called the dent.
Oh my God.
The compliance dent. Let me take one last word on this topic.
Yeah.
And if somebody wants to say something afterwards, but if not, I'll because we're running close on time here. I'll take the last word on this one since it's right in my wheelhouse. Here's the thing. offering services for free to other physicians can potentially be illegal because it violates the anti-kickback statutes. It potentially violates Stark law, and it violates potentially your your state laws. But beyond that, we also have to take into consideration things like fair market value, but most importantly, it undermines the ethical standards and patient trust that they put into us. It's important to keep in mind that the laws and regulations are created, they're put in place to ensure that healthcare providers only make decisions based on the best interest of their patients and that they are free from any undue financial influence. So at the end of the day, it comes down to this: compliance is crucial to maintaining the integrity, but more importantly, the trustworthiness of providers within our industry. So I thank Terry for this last one because you gave me a blog topic that I'll think about for the next 24 hours and put something together and maybe tackle each of these different statutes, acts, laws, and ethical conundrums. So with that said, we got about 3 minutes left. Any last words from the panel? Christine, I'll start with you.
Well, I think this was an amazing show. We talked about a lot of real things that we deal with on a regular basis, and we brought light to a lot of issues that maybe provider organizations aren't really thinking are big deals until it comes and bites them. So I really enjoyed this session here, and I appreciate everybody's input on it. And I didn't mean to point out anybody's big nose in this session.
Paul, I got to come to you next because I know I see that smirk on your face.
Well, being a fan of Borscht Belt comedy, I know a thing or two about big schnozolas, but I'll just pass and defer to the rest of my colleagues.
All right, Stephanie Allard, what you got?
If I can get mute off here. So yeah, I just wanted to reiterate, when we talk about all these various things, it seems pretty obvious, but I'm still encountering a lot of people in the industry that are just letting this stuff fly by because it's what they're being told from maybe a payer that shouldn't be saying that to them. It's what they're being told, even maybe from consultants or things like that. There's so many things I've been dealing with recently with practices really in a deep hole, and a lot of it is because they were listening to everybody else instead of really paying attention and focusing and even researching on their own. You need to understand why you're doing something.
Excellent. Scott Kraft.
The one thing I wanted to add, I would mirror Christine's point that I think we had a great panel today. We had really great topics. I think in terms of physicians and no charges and things like that, you really don't. We're talking about incredibly nominal sums of money here at the end of the day versus inviting the attention and focus of the government of the United States. Whenever you see something that says United States versus, you really don't want to be on the other side of that versus, unless maybe you're like a soccer team, because we don't really do good with that. But, you don't want to be at risk, and it's one of those things where, if I came back to somebody after the fact who got indicted or who got investigated and ended up spending 5 or 6 figures on it, and you'd say, well, was it really worth it for that, whatever amount of money you saved your friend or whatever amount of money that you each gained from this arrangement? And the answer is almost certainly going to be no.
Yep.
Yeah. And the last
All right,
thing
Terry, last but not least, my friend.
Last thing, remember why you're listening to this podcast. It's the compliance guy. We are really just trying to hope and instruct and encourage you to have compliance plans. It's not just in the revenue cycle management, the back office, the physician office. It's, in how you charge cash patients, how you don't waive deductibles and copays. But in all aspects of your practice, you should have compliance. And that means everyone should be let in on what that is. It should be something you can pull those policies, something that's tangible in writing, that's not just on the fly made up. And it's required if you are taking federal money. So that's the last thing I have to say.
All right. So that's going to do it for this episode of the Compliance Guy, our Monday auditing, coding, and compliance roundtable. Again, I want to thank Christine, Stephanie, Paul, Scott, and Terry for joining in on the fun today. And thank you to each and every single one of you across all of these different platforms that's tuned in, logged on, and hung out with us for a little while. Thanks for engaging in the show, sending your comments, your questions, your emojis, your reactions. We always appreciate those things. Terry and I are going to be back tomorrow with a brand new episode of the Compliance Guy #Terry episode. I can't wait to see what topic she springs on me right at the start of this session. And then Thursday of this week, I will be releasing the episode that I was able to record last week with Dana McMahon of Stryker. She is the global chief compliance officer for all of Stryker Corporation. It was an absolutely brilliant conversation. Can't wait to introduce her to all the listeners and followers of the Compliance Guy Show. So until then, remember, be good to yourself, but more importantly, y'all be good to each other. Take care.